Hello, my name is Dr. Sebastian Barr, and I'm very happy to be presenting an introduction to a project that I'm working on with some esteemed colleagues, Doctors M. Matsuno, J. Bettergarcia, and KJ Connor. We're working on guidance for psychotherapists whose clients or patients are experiencing distress related to gender dysphoria, and guidance that specifically addresses ways that psychotherapists can facilitate relief from this gender dysphoria related stress. Some important pieces to lay out at the beginning here. We draw from our lived experiences, the stories of our communities, our clinical experiences, and our training. So we recognize that this gives us some helpful grounding, but also that our perspectives are constrained by who we are and whom we are connected to. Additionally, we want to name the very real cissexism and white supremacy that exists insidiously within the institution of psychology. We believe in the power of the side disciplines to work for liberation and healing, but recognize there are some real limits to trying to do this work while positioned within these fields. Additionally, we want to underline that we resolutely support access to gender affirming medical care, such as hormone therapies and surgical interventions, which are evidence-based treatment for gender dysphoria and an important component to supporting the well-being of trans and non-binary people. We're going to be proposing psychotherapy approaches that may bring some relief, but these should never be stand-ins for facilitation of transition or gender affirming medical care. First of all, let's briefly define the term gender dysphoria. We are speaking here about a psychological construct and not the diagnostic label. Cooper and colleagues conducted a phenomenological review of the literature of gender dysphoria and suggested that there are four categories of experience contained within the construct of gender dysphoria. The first, distress due to dissonance of assigned and experienced gender. The second, interface of assigned gender, gender identity, and society. Three, negative social consequences of gender identity, including distress due to misgendering. And four, internal processing of trans negativity and rejection. So there's this underlying incongruence or sense of disconnection from or lack of ownership of parts of the physical self. But there are also critical social components in terms of how a person is being perceived or imagines they are being perceived in relation to their gender. And then the internalization of trans negativity and cisgender norms or ideals may contribute to distressing experiences of gender dysphoria as well. Gender dysphoria is often experienced as incredibly painful and a source of rumination. The degree to which it causes problems for folks varies, and there are some trans and non-binary people who do not endorse having these experiences. Obviously, describing the wide range of experiences of gender dysphoria is its own category of work, and we can't fully get into it. There are some excellent papers that do a more thorough job of this, which we recommend here. This PowerPoint is a handout, so please come back to this and check out these papers, many of which are authored by openly trans researchers. Okay, so why should therapists be concerned with this? Well, we know that gender dysphoria is related to overall mental health and well-being. So that's reason enough. And while often the best course of action is to facilitate gender affirmation steps like social and medical transitions, there are situations in which that alone is not going to resolve the dysphoria related distress. So for example, not everyone can access care due to barriers like cost and provider competence or contraindications. And some clients may not feel safe or want to pursue gender affirmation at that time, but are still experiencing gender dysphoria. There are routinely delays in accessing care or in experiencing the benefits, so wait lists, but also it can take a while to experience the effects of hormone therapies. So while effective sustaining relief may be in the future for a client, that person may be facing moderate or severe distress in the meantime. Additionally, there are situations in which some pieces of dysphoria can persist, return, or be triggered even after successful relief of a bulk of the dysphoria via gender affirmation. As a therapist who works with many trans and non-binary folks, gender dysphoria comes up routinely, but we really lack clinical guidance for how to be helpful in this area. You can Google how to cope with gender dysphoria and get community-generated lists and guides that are often really helpful. There's literally an illustrated WikiHow. But for clinicians, texts on being affirmative highlight the evidence in support of supporting transitions. But we believe therapists are uniquely positioned to aid in this even further, to have a role beyond the important one of facilitating transitions. We obviously don't have time to provide any actual training on this today, but we wanted to give a very quick overview of some of the ideas that we'll be talking about in our forthcoming paper and some subsequent trainings. First, we believe there are some overarching principles that need to be adhered to in order to have a solid foundation from which to address gender dysphoria. An affirmative stance, so clinicians who are not affirming of their client's gender identity, expression, related needs, and autonomy are just not going to be effective partners in this work. Additionally, research has demonstrated that non-affirmation and trans negativity can operate as insidious trauma, and the trans community has high rates of exposure to more traditionally defined traumas as well, like assault. Being mindful of how a client's presentation and needs may be affected by trauma will be critical, especially as reflection on gender dysphoria could easily be triggering. Finally, clients' experiences of and needs around gender dysphoria and identity will be shaped by their intersecting experiences and sociocultural context. So clinicians must be mindful of their client's whole self in this work. There will be no uniform model and no prototypic client. In terms of interventions for gender dysphoria relief, one set of interventions revolves around establishing understanding of the client's gender dysphoria. Uh, Dysphoria experiences are going to be idiosyncratic. So as a clinician, careful listening and exploration will serve in part as assessment and will be vital to conceptualizing the experiences and needs of each individual. But we also argue that conceptualizing that this exploration is helpful in its own right for the client as a way of promoting a more mindful relationship with their dysphoria and identifying triggers. This is also consistent with insight-oriented models of psychotherapy. For example, Austin and colleagues briefly recommend the use of narrative and emotions-focused interventions that help clients utilize metaphor and or creative nonverbal expression of experiences and emotions to increase self-understanding. This suggestion follows their finding that participants in their qualitative study often spontaneously used metaphor to illustrate their painful experiences related to gender. There are important relational interventions possible in psychotherapy when the therapist works as an affirming mirror through which a client can experience being seen by another in alignment with how they see themselves. There are ways that this happens both implicitly and explicitly. For some clients, therapy may be the first place where they get to hear new pronouns or a new name used for them. Depending on a therapist's theoretical orientation, it could be fruitful in identity development to process the client's experience of the therapist's representation of them and their gender. Cognitive interventions can help clients deconstruct harmful beliefs at the root of some dimensions of gender dysphoria, like internalized transnegativity and idealized cis norms. Further, thought patterns that can catch any of us up around anything can exacerbate the distress of gender dysphoria. For example, all or nothing thinking could amplify an experience of mild dysphoria into a protracted, moderate, or severe experience. Attending to unhelpful thought patterns, internalized transnegativity, and unrealistic cis norms is the first step to doing work to challenge those. There are different approaches for shifting these beliefs depending on theoretical orientation. One CBT based intervention is presented in Israel and colleagues' 2018 paper and was found to be effective in reducing shame and increasing pride. Intentionally increasing exposure to celebrated body and gender diversity is also an important environmental or behavioral intervention that could shift some of these beliefs or deconstruct them. We also believe there is potential for psychotherapy to be a space that can motivate ways of relating to the body with more compassion and collaboration and connection, focusing on non-gendered relationships with the body, how bodies can be sources of pleasure, safety, and empowerment. We also see a great deal of potential for the incorporation or adaptation of somatic techniques that help clients feel safe reconnecting to their bodily experiences, though we caution this must be informed by the awareness of the potential that body directed attention can trigger distress and lead to flooding or more dissociation. Speaking of flooding and triggering, an important element of helping clients manage gender dysphoria is building the capacity to experience and regulate distress. Sloan and Shippard have offered guidance on how to shape DBT interventions to be particularly relevant to the sources of difficult emotions that trans and non binary people face. They note that chronic invalidation that trans folks often experience can prevent the development or use of effective emotion regulation strategies. Um, there are other therapeutic approaches from ACT to psychodynamic work that can be incorporated to improve emotion regulation and distress tolerance. I think some might argue that this is a fundamental piece of what we do as therapists generally, anyway. Last but very much not least, we propose that using psychotherapy to build sources of resilience is critical. Specifically, we highlight that work can be done inside and outside of therapy to identify what makes the client feel gender euphoric or particularly embodied. Helping a client build more of this into their lives generally is helpful. And it's also valuable to have accessible sources of gender euphoria and embodiment that clients can reach for when feeling particularly dysphoric. Other sources of resilience include broad well being factors like sleep and physical care, and factors specific to the trans and non binary community. We recommend incorporating Matsuno and Israel's trans resilience intervention model as a component of this work. So this was a very fast overview of elements of an ongoing project. We welcome feedback and dialogue, and we really thank you for your attention and for engaging with this. And hope you have a great rest of the conference.